Hi, everyone, and welcome to another one of the American Physician Scientists Association's interactive sessions. So tonight we're going to continue with an exciting week with PSTP Pathways Week. All week we've been featuring specialty-specific conversations with PSTP residency program directors. And tonight's session will feature representatives of urology, OB-GYN, ENT, and anesthesia. And so let's start with some quick introductions from our panelists who've joined us tonight despite their busy schedules. And so if you could please say your name and which institution and specialty you're representing. So first with Dr. Blair Stocks.
Hello, I'm Blair Stocks. I'm a urologist down in Houston, Texas at Baylor College of Medicine, and looking forward to chatting with y'all.
And next, Dr. Kjersti Aagaard.
I am Kjersti Aagaard, and I am now a physician leader with HCA technically I'm Nashville, but I still live in Houston, and my academic appointment is with Boston Children's and Harvard.
And Dr. Dev Basu.
Yeah, hi, I'm head and neck surgeon scientist in the Department of Otolaryngology at the University of Pennsylvania.
And next, Dr. Nishant Agrawal.
Hi, everyone. Nice to meet you. I'm also a head and neck surgical oncologist. Similar to Dev, I'm an otolaryngologist at the University of Chicago, surgeon scientist with a focus on cancer genetics and biomarkers. Excited to talk to you about becoming a surgeon scientist or physician scientist.
And finally, Dr. Charles Emala.
Hi, I'm Chaz Emala, anesthesiologist at Columbia University in New York. Looking forward to sharing some insights into PSTP pathways in anesthesiology.
Great. And my name is Nicole Petit, and I'll be the moderator this evening. I'm a rising M2 MD PhD student at Texas A&M. And behind the scenes are Monica Rasmussen, who will be managing the chat and logistics, and Bree Brammer, and she will be live tweeting highlights from our conversation. And just a quick note, if you need to step away, don't worry, the session will be recorded and will be made available afterwards on the APSA YouTube page. And so we'll first start with a few brief presentations from our speakers, and then around 7:30, we'll move into breakout rooms where you can connect directly with our panelists and ask your questions. And so let's first start off with Dr. Stocks, who will give an overview on our urology PSTPs.
Sure. All right, let me just share my screen real quick. Oops, hold on, let me make sure I can share. Sorry about that. You know what? Can I go second or later? I'm so sorry to interrupt the thing, but my settings are a little off. So I apologize for that. So if I could just go second, is that okay? Or afterwards? Okay, great, thanks.
Dr. Basu, would you like to go next?
Sure. Let's see, I can share my screen. Here. And can you see my slides okay?
Yes, we can see them.
Great. So maybe I'll say a little bit about my journey in this specialty and what the training environment is like for people who want scientific careers. Just briefly, the reason to think about being a surgeon scientist, a big part of it is you get to be a surgeon, which is intensely appealing, I know, to some of you, and intensely not appealing to others. But the point is that it is possible as a surgeon. There are perhaps some extra barriers. You know, if you want to do it, you bring a distinct perspective that can facilitate certain types of innovation that your colleagues won't be able to. There's some access to patient-derived materials and data sets in a way that others don't have, and it's very important to figure out how to leverage that. it's a little bit more rare in the surgical specialty, so there may be a sort of a specialized niche for you, and later in your career, your sort of rarity may give you the perspective that's valuable in certain types of leadership roles. There are challenges. They're surmountable. The clinical training is longer than your internal medicine, pediatric, pathology colleagues, fields that are rich with clinician scientists. The path is less well defined, and I know we were supposed to talk about formal training resources, and these are a little bit sparse. There are 1 year and 2 year T32 and T25 residency programs. Those are great resources to kick off a scientific career, but and I've lost track of which ones those are. We at Penn don't have one. We're still exploring starting one, but people manage to do it regardless through various mechanisms. There's bigger gaps in your research training based on the length of the clinical training, which is 5 years, and these days typically followed by fellowship. You may feel you're more rare, so you may feel a little bit more of an intellectual and cultural gulf with some of your clinical colleagues. And you may have to do more because the infrastructure isn't as strong. You may have to do more legwork on your own to find the right set of mentors, which is absolutely critical. I don't know if there's fewer jobs per capita, but there's fewer total jobs, and so they're more scattered about, and the timing is more critical. And one could reasonably argue that it's harder to protect time for science because you really got to be in the operating room around 1 day a week to make this a viable thing. Something you ought to think about if you're going to be a surgeon scientist is which leg of the race of creating knowledge to the patient you want to run, and there's many of them. And as a scientist, many of us want to be over here creating fundamental insight, but often you can leverage your resources more effectively in these other legs of the race, and you got to figure out how to do that. And so, this is kind of the imprint that I've slowly developed over time that allows me to use the resources that I have at hand. Just to say something about my path, the reason I chose this field, specifically head and neck surgery within ENT, was we were doing big cancer operations for serious disease. Perhaps, at least in my case, at my institution, the culture was a little more appealing in ENT than in certain other surgical disciplines that I was exposed to. The patients aren't, even though these are big surgeries, the patients weren't quite as sick, so the peri-op care burden was perhaps a little less. There was, there's limited scope of research activity. Sometimes in residency, you really have to go out of your way if you're not in a dedicated training program. And so you have to reconcile yourself with that clinical world. One thing that I did figure out towards the end is that surgical competence can be maintained without the kind of full-time effort. And I think a lot of people are scared with that because you think, well, learning to be a surgeon is overwhelming, but the truth is you get there. So anyway, just the challenges for me from bridging from my residency to my faculty career, which is really where you want to go in the end. It's finding diverse mentors with complementary expertise, aligning their interests with yours. No single mentor is ever adequate. You're constantly retraining. I'm still retraining and learning new things, but you have to be devoted to it. I've retrained as a cancer biologist in between residency and my faculty job. Starting off trying to publish substantive work in a field that was somewhat unfamiliar. Coming into it, that's a big hump. Funding there's a lot to say about that. I think this is probably not the venue for that, but I'm happy to talk more about that. Running a scientific enterprise is like running a small business, attracting, hiring, training, managing, and those tends to be big hurdles that you may not be that equipped for. And then just building up that network of collaborations and connections within your institution and outside in your institution that makes your career go. So with that, I'll end and unshare my slides.
Thank you. And so for next, Dr. Aagaard will be giving an overview on OB-GYN PSTPs.
Okay. All right. You should see my screen. Are we up? Slides. Okay. Okay. So in talking through OB-GYN, I wanted to just kind of give a little bit of background because I think we would all have very, very similar comments around the training in the surgical subspecialties. And so I am maternal fetal medicine, which means I specialize in high risk obstetrics. And I absolutely love what I do, and I love the science that I've done. I was heavily trained in genetics as well. And so I cross a lot of the different worlds that I've always loved. And like many of us, you know, our MD PhD years were some of kind of our highest highs and our lowest lows. So many of you guys are starting in those years, but they're tough years, and they're tough years for a lot of reasons, in part because you're always feeling this pull between what your mentors kind of expect you to do and what it is that your heart really leads you to do. And I think, you know, probably a common theme you'll hear from all of us is that when we go into the surgical specialties, we do it out of a pure love for the medicine that we practice. It is a harder route because you do have to kind of maintain a certain amount of clinical competency, because the margin of error is a very, very fine margin of error, especially in high risk OB and especially in the state of Texas. But you kind of walk that line, and I would say you know, like many of you, do your first rotation back in med school, and I did OB-GYN because I thought there was no way I'd go on to be an obstetrician gynecologist. I was going to be, you know, either infectious diseases or hemonc. And I did my rotation and I loved it. And part of the reason I loved it was because I knew I could be a fierce advocate for my patients for the rest of my career. So I did my residency, continued to have quite a bit of research throughout my residency. I was fortunate that I had a wonderful PhD thesis mentor, and so I had quite a few high impact publications during my thesis work. And went on and did a few more back in med school, and then went on and did my residency. And because I've published on this as part of Nature Medicine, profiled a number of us several years ago who are physician scientists, you know, my life caught up with me a little bit, and I found myself a single mom with 3 children. And so that's, you know, a hard thing to find yourself in the middle of residency. I chose not to disclose that to any of my faculty members, kind of pushed through. In my residency at the time, we were Q3 call, and it was a little bit different era than it is today. And because I was concerned that I wouldn't get into a highly competitive fellowship. And so made the decision to do maternal fetal medicine, moved to the University of Utah, where I dual trained in maternal fetal medicine and genetics, and built really a pipeline for the research I would engage in for the next 20 plus years as a faculty. I was recruited to Baylor College of Medicine and Texas Children's, and really followed a wonderful trajectory. And I had 20 amazing years I would not change for the world. I became, you know, vice chair. I led our MD PhD program for about 13 years, was endowed chair. And really, I found that my career exceeded my expectations as I hit the end of my kind of 20-year mark, and was recruited by HCA Healthcare. And so for those of you who don't know HCA Healthcare, it's the largest hospital system in the world. We have over 250 hospitals in the United States, including about 160 that do OB-GYN and delivery. So we account for about 1 of 4 babies born in the United States. So it's a very large volume with a huge amount of impact. And they recruited me to be the national medical director. They promised me I could stay in Houston, where my husband is the president at Texas Children's, and also a physician scientist. And so it was a opportunity I couldn't pass up. And the way I really summarize it is that it gave me the opportunity to bring research and clinical care to people where they live and where they work, and became involved in community care. It turns out we're a very large presence, especially in the greater Houston area. We account for about 40% of all deliveries in Houston. We're about 85% in Austin and about 60% in San Antonio. So we're a large presence with a big footprint. And right now in Texas, it gives us the opportunity to really lead in meaningful ways to reduce maternal morbidity and mortality. And nationwide, we have quite a bit of access and do a lot of research through the HCA Research Institute. And I moved over my academic time to that. As I mentioned, I talk a little bit about the highs and lows of the journey as a physician scientist. This was published in Nature Medicine a couple of years ago that they asked us to do it. And I think it's sometimes important to recognize that there will be highs and lows in your career, and there'll be times in which your personal life needs to take a focus, and there'll be times when your professional life needs to take a focus. But it all seems to really work out in the end. It's made me a better physician, not having always led a perfectly charmed existence where everything went well at home, and I had to kind of make some different changes and priorities. I would also say, professionally, I always took advantage of being able to share my clinical skills and surgical skills in different corners of the world. I absolutely love my lab and was continuously funded and still funded with NIH. And also got to engage in some huge projects like the Human Microbiome Project. I led that for Baylor with my now husband. And so just had amazing graduate students and mentors and just an incredible life, and have gotten to really reap the benefits from that over time. And so with that, I'm going to pass it on to kind of the next person. I would just say that, what most of us say in the surgical subspecialties is that the days are long, but the years are short. And so, we really get to make a tremendous impact in people's lives. We're kind of, for most of us, we're the end of the line. We like being the end of the line. We like being comfortable with critical care management. We like being comfortable with our surgical skills. And we take a lot of pride in both aspects of what we do. But it does involve some intensive and always feeling comfortable with your clinical skill set. Because again, patients' lives are on the line, and that margin of error is a very small one. So with that, I'm going to turn it back over to one of my colleagues in one of the other subspecialties.
Thank you, Dr. Aagaard. So next we'll have Dr. Stocks, who will give an overview of urology PSTPs.
Perfect. Okay, let me share my screen, and then can everyone see my slides? Is that working? Okay. So just brief introduction, also a Houston person. So my name is Blair Stocks. I'm an assistant professor of urology at Baylor College of Medicine, specifically in the division of male reproductive medicine and surgery. So I'm much more junior than those who have presented thus far. So it's a little more early career development, a little more focused on what sort of immediate opportunities there could be in urology training to kind of complement your research and scientific desires. And I have my email address there too. If you have any follow-up questions, I'm more than happy to get back to you. Okay, so there's me. I did my biomedical engineering degree at the University of Virginia, and just kind of to reiterate a point that some of my colleagues have made this far, it's definitely long training. So I always like to calculate, what grade I am in at each of these sort of junctures. So I finished my biomedical engineering degree in 2010, but really kind of fell in love with basic science in an engineering lab I was in. So I applied to the MD PhD program at Vanderbilt, which was a phenomenal experience, and found my love for cellular immunology at the time, and sort of flow cytometry, advanced flow cytometry. And then by the time I graduated, I think in 2018, I was in the 24th grade. Just sort of, a kind of another point that I would like to reiterate is always follow your mentors. You're going to have a lot of good mentors in your career stages, and really try to find those that want to push you and sort of work with you closely. And that kind of sort of guided my career. So at the time, being a cellular immunologist, I thought, of course, I was going to do transplant surgery. I really liked working with my hands. Did one rotation on transplant as a med student, and realized I did not want to be flying somewhere at 2 a.m. So luckily, Vanderbilt had a great urology program, and I kind of stumbled my way into that and kind of found a love for the surgical aspect of it, the clinical aspect of it, and kind of the breadth of it, from pediatrics to the oncology side of things. But I was fortunate enough to actually do an away rotation during my med school training and found sort of the field of men's health and infertility kind of just by pure happenstance, and got to rotate with one of the leaders in the field, Larry Lipschultz. And as a med student, I was like, this is definitely where I want to go for urology, what I'm interested in. So I was fortunate enough to match at Baylor College of Medicine. We did 1 year of general surgery internship, which is kind of shifting away from the general paradigm now, and then subsequent 4 years of urology. So by the 29th grade, I had finished my urology residency and then chose to stay at Baylor with my mentor, Dr. Lipschultz, and did a 1 year fellowship in male reproductive medicine and surgery. So I finally finished by grade 30, just again to how long the training can be, but I chose to stay on as faculty there. So I'm about a year and a half now into my faculty position at Baylor College of Medicine. And it's kind of nice right now to the point of, you're not going to be perfect at anything as a physician or surgeon scientist, but you have to have enough training to be good at it. So I spend 1 day in the operating room. I basically have 2 days in clinic, 2 days of research, and then another quarter or an eighth of my time at the VA, which is very nice too, to give back to that population. So basically, just being a little closer to the training period. When you're considering a urology residency, basically they're 90% are 5-year residencies. There are a few 6-year residencies that have a dedicated research year. And there's actually an option for an 8-year residency through, which I'll describe on the next slide, the Urology Care Foundation, where they basically have 3 years of dedicated research built into that residency. So just to give you an idea of the scope of urology, there's 143 programs participating. There's an early match, so you get to learn before all of your fellow medical students where you match, which is kind of nice. So there are a number of programs, but I think the big question that you want to think if you're already in sort of the scientific mindset is, do I feel like a dedicated year or more of research during or after residency is needed? So if you are looking at the 6-year programs, these researchers are generally mid-residency, sometimes plus or minus call or responsibility. It kind of depends on the specific program. But I think a big question is, think about your prior training. So if you are in an MD PhD program, as I was, did I feel like a 6-year program with that built-in year would really advance my career? And personally, I felt no, because it's kind of hard to get any project going at a new institution for a year to be culminating or shifting your research path that much. So I personally chose just to do a 5-year program so I could then expedite my pathway to faculty positioning a little earlier to get the ground running. But then again, if on the flip side, if you've come to the research game late, not that it's bad by any means, but if you've done strictly MD DO training, maybe that 8-year residency would let you have that dedicated time to potentially expand your research knowledge. Especially important if you're pivoting research interests. So yes, I have a background in immunology, but now I generally do male infertility. So there is a little bit of a pivoting research interest. Do you need to find a new mentor? Do you need to start collecting preliminary data for something like a career development award? So just sort of asking yourself where you are now and what do you foresee your future in urology residency and research is pretty important. And again, to the same point, a new mentor, moving institutions. Kind of the point above, there's fewer and fewer 6-year programs. Some of the 6 years are required versus optional research year. But unfortunately, in my case, my 5-year research program actually did have a dedicated 6-month research block. So that was something that attracted me, where 6 months during my 3rd year, I actually had 60% of my time dedicated to research. So I was a little operating on 2 of the days, but it gave me that time to sort of build some preliminary data that I needed for some papers that I was working on at the time. Additionally, there are some post-residency, postdoctoral training grants specifically for urology that kind of fit under the T32 umbrella. So after residency, there's still options to have advanced training at the postdoctoral level. So just a great sort of where everyone is in training, a great sort of resource for urology research opportunities is the Urology Care Foundation. So basically, there are a couple ones I just wanted to highlight if you are interested in the urology side. There's summer medical student fellowships. There is residency research awards that you can get a certain amount of months with built-in research time. But specifically when it comes to the PSTP path, there's not a lot of PSTP specific programs for urology. There's just not as many, say, as in medicine or things like that. But through the Urology Care Foundation, there's actually the Physician Scientist Residency Training Awards, which basically within your participating institution, there's 3 of which now, Michigan, UCLA, Washington, they'll carve out 3 years of funded research time for that. So I think there's been one thus far since 2017, but it's still awarded, or the application is open every year if that is of interest of you. Kind of just, again, with surgery, I would say, research in a surgical subspecialty is definitely a choose your own adventure kind of field, but it's doable. You just kind of find the right mentors and the right research opportunities. So with that, I'll stop there and hand it over to everyone else. Thank you so much.
Thank you, Dr. Stocks. And so for our last overview, we'll have Dr. Emala, who will be discussing anesthesiology.
Thank you. Can you see my screen okay?
Yes, we can.
Thank you. So it's a real pleasure to talk to you about PSTP training in anesthesiology. And very often there are misunderstandings or assumptions about the types of research that are available in anesthesiology. So I wanted to start sort of to share the breadth of possibilities. Many would assume that anesthesiology focuses on the brain, the neuroscience, consciousness, and so forth. And while that is true, anesthesiologists deliver not only perioperative care in the operating rooms, but work in intensive care units and pain clinics. And the breadth of research is really reflective of that breadth of clinical practice. Anesthesiology research really spans many pathophysiologies because of the diverse array of disease states that present for perioperative care. It focuses on all extremes of age, from neonatal neurodevelopment to geriatric cognitive outcomes in the perioperative period, and really spans basic clinical and epidemiology research. Examples from cryo-electron microscopic structure, protein interactions with drug molecules, to epidemiology, clinical outcomes of large patient populations. So anesthesiology really touches on a diverse array of basic and clinical research because anesthesiologists provide clinical care across an entire spectrum of pathophysiologies, age groups, and population health arenas. This is a little bit of a word map of some of the more common areas of research that are funded in anesthesiology. Again, a fair amount of neuroscience, consciousness, pain, as well as intensive care unit, organ protection, inflammation outcomes, mechanical ventilation, etc. So the typical training pathway in anesthesiology involves a 4-year residency program. The first year is a transitional internship, followed by 3 years of clinical anesthesiology. The American Board of Anesthesiology allows up to 6 months of that time to be devoted to research. There are very often followed by a 1-year clinical fellowship. Within anesthesiology, there are 6 accredited 1-year clinical fellowships in critical care, pain, cardiothoracic anesthesia, pediatric anesthesia, regional anesthesia, and obstetrical anesthesia. An alternative pathway for those more interested in devoting that fellowship year to research is to do a non-accredited clinical research, which in many departments includes clinical training in neuroanesthesia, transplant anesthesia, and critical care anesthesia. The opportunity during that year is formulated in a way that really maximizes the opportunity to do research, usually up to 80% of research time during that clinical fellowship. This is commonly followed by 2 years on a training grant. There are currently 20 T32s in anesthesiology across the country. I'll touch on a little bit more. And we're very fortunate in the specialty to have a few foundations that support the development of physician scientists. I often refer to these as 2-year K awards. They're formulated and structured very much like an application for a K award, although many folks don't wait till the end of that to pursue K award applications. So I wanted to refer you to a number of really useful websites, and this first one is not limited to anesthesiology. It's actually from the AAMC PSTP website, and you can see at the bottom the number of specialties that have links to information on PSTP pathways within their specialties. Anesthesiology is one of those links that will take you to a lot of information on PSTP training programs and academic opportunities. This is not meant to be read, but just to show you a brief list of anesthesiology residencies that have PSTP programs. And again, the QR code will take you to this list, which is maintained on the AAMC website. As I mentioned, many of these programs have T32 training grants, up to 20 in the country, and some of them have dedicated, unique matching processes through ERAS, where programs such as Columbia will have a number of positions that have a separate match code for our PSTP path versus the categorical residency. We're very fortunate to have a number of societies and foundations within the specialty that fund early stage investigators. Very often these are grants that happen either out of clinical fellowship as a junior faculty member or while transitioning off of a T32 training grant. Full disclosure, I'm a board member of the Foundation for Anesthesia Education and Research, which is probably the flagship organization that provides 2-year awards at the level of a K award. And again, is structured very much like a K award. The International Anesthesia Research Society has similar awards. And the Early Stage Anesthesia Scholar Society is a group of early stage physician scientists who do a lot of programming at our national meeting for career development and so forth. So I'll stop there and happy to answer individual questions in the breakout rooms, or feel free to contact me by email.
Thank you, Dr. Emala. And thank you so much to our panelists today for sharing your time and advice with us. We're very grateful for the mentorship and perspectives that you've offered. And we're now going to transition into breakout rooms so that you can connect directly with our speakers. And so there will be a selection of breakout room options on the screen. You can simply choose which room you'd like to join, and feel free to move between rooms if there's more than one specialty that you'd like to explore. And so with that, we'll open up the breakout rooms.